The modern neuroscience of Alzheimer's disease rests on a contradiction. We have decades of robust, peer-reviewed evidence pointing to amyloid plaques as the primary cause. We have equally rigorous data pointing to tau tangles, and parallel literature proves the disease is driven by the failure of microglial immune cells. Because the field has split its focus among these competing molecules, clinical trials have spent years targeting them in isolation. Single-target monotherapies, designed to clear amyloid or neutralize tau, have consistently failed to halt cognitive decline in broad clinical populations. In 1907, Alois Alzheimer's contemporary, Oscar Fischer, observed the characteristic neuritic plaques in the brains of demented patients. He recorded them as morphogenetic events, active structures with a distinct developmental history radiating from a center. But the century that followed abandoned Fischer's observation, choosing to view the disease through the lens of inert substances rather than biological processes. Those repeated clinical failures are the direct result of that structural framing error. The field has treated the disease as a static chemical imbalance, when the biological evidence describes an active process unfolding in time. These competing molecules are successive, load-bearing lesions marking the advance of a single front of cellular failure, a process that spans 50 years. This 3D map illustrates that temporal architecture. It correlates 3 anatomical regions, brainstem, hippocampus, and cortex, with a timeline from the 3rd to the 8th decade. A neuron moves through 3 states: metabolic dysfunction, cellular senescence, and finally, network death. To trace this architecture, we have to start at the actual point of origin, decades before the first clinical symptom appears. This schematic isolates the locus coeruleus in the brainstem, where Alzheimer's begins in patients in their 20s. A single neuron projects a vast axonal tree across the entire forebrain. Firing continuously, it operates near the absolute ceiling of its metabolic capacity. Operating at this extreme limit leaves no reserve to manage the age-dependent decline of NAD+, the central currency of mitochondrial metabolism. As NAD+ depletes, the neuron loses its ability to execute mitophagy, the critical process required to clear out damaged mitochondria. At the same time, amyloid beta proteins physically bind and obstruct the TOM40 channel, the exact pathway mitochondria use to import the proteins needed for repair. The genetic locus that encodes this channel carries some of the strongest known risk factors for late-onset Alzheimer's. With clearing mechanisms compromised at both ends, from the formation of autophagomes to the acidification of lysosomes, the cell begins to swell with undigested cargo. The neuron falters, but it survives. This establishes the first phase of the architecture, pure cellular dysfunction. The disease waits here in a clinically silent state, causing only subtle shifts in sleep and arousal for up to 2 decades. The locus coeruleus acts as the disease's active vector, utilizing its vast axonal tree to distribute the lesion across the forebrain. This diagram maps transmission to the hippocampus. Normally, noradrenaline acts as a brake, suppressing immune responses. As the projection fails, this brake lifts, activating localized inflammatory microglia. Simultaneously, these failing axons deliver pre-tangled tau seeds up the ascending projection to destination neurons. The arrival of this dual cargo coincides with the activation of the aging cerebral endothelium. The blood-brain barrier transitions from a strict shield into a leaking conduit, exposing the local tissue to pro-inflammatory signals from blood plasma. The disease advances through a precise convergence. A failing projection, a lifting brake, and a leaking barrier all meet on the hippocampus at the exact same time. This convergence establishes the bridgehead for the second phase of the disease, unfolding in the hippocampus during a patient's 6th and 7th decades. Under chronic inflammatory load, the TGF-beta SMAD signaling pathway breaks down. This specific chemical program is what normally holds the brain's resident microglial cells in a resting, custodial state. Without that restraining signal, the microglia exit homeostasis. Depending on their specific TREM2 receptor function, they drift into various aberrant trajectories. The cells gorge on local debris until their internal cytoplasm becomes completely gridlocked with fat, leaving them metabolically exhausted. The transition marks the loss of the biological governor that normally maintains homeostatic microglia. locking the resident immune population into a state of irreversible senescence. Moving from this state of immune collapse to the actual destruction of synapses requires the breaching of a rigid physical barrier. This diagram represents the perineuronal net. Microglia flip a proteolytic switch, secreting matrix-degrading proteases that cut directly into the structural envelope. As damage progresses, released redox active iron reacts to produce hydroxyl radicals, causing rapid oxidative fragmentation of the matrix. The senescent macroglia then deposit C1q complement proteins onto the fragmented matrix. These proteins act as biological tags, licensing the full phagocytic stripping of the remaining protective sheath. This combined enzymatic and inorganic assault completely digests the structural envelope, marking the completion of the second biological transition. By the 8th decade, the process reaches its final biological destination in the cortex, the fast-spiking parvalbumin-positive interneuron. These specific neurons act as the metronome for cortical computation, generating the high-frequency rhythms required for working memory. Because of their extreme firing rate, they completely rely on the perineuronal net as an antioxidant shield to survive their own metabolism. When the proteolytic turn strips away this dense mesh network, the delicate cell structure beneath is left completely exposed. The loss of the matrix also destroys its embedded N-sulfated heparin sugars. These specific sugars are required to stage protective reelin signaling, which restrains tau accumulation. Digesting them simultaneously withdraws the cell's shield and opens the gateway for incoming pathology. Without their protective envelope, these crucial interneurons suffer an immediate excitotoxic death. The resulting loss of inhibitory tone collapses the excitatory-inhibitory balance of the entire cortical network. That specific structural threshold is the event we clinically experience as terminal dementia. This architecture reveals a single continuous system collapse spanning a half-century, a trajectory carrying a cell from initial dysfunction to senescence and finally to death. Nature has already proven this unity. This schematic shows the 3 required layers of cognitive defense: homeostatic microglia, an intact structural matrix, and competent synapses. Patients with extreme genetic resistance to Alzheimer's, like carriers of the Christchurch or Calbos variants, survive by tightening the structural integrity at the central matrix node, directly blocking the mechanism of tau uptake. This architecture explains the failure of single-target clinical trials. Administering a drug designed to fix Phase 1 metabolic dysfunction to a patient currently undergoing Phase 3 structural collapse is biologically ineffective. True resilience requires the joint preservation of all 3 layers simultaneously. That points to broad, unifying homeostatic targets, like the TGF-beta SMAD signaling pathway, which controls both immune restraint and structural maintenance. By viewing Alzheimer's as a 50-year observable clock, the parameters of treatment change. The opportunity to halt the disease is not restricted to the brief window after diagnosis. The opportunity exists in the decades before, acting on the homeostatic signals that erode long before the final network breaks.